Good afternoon, everyone, and thank you for joining us this afternoon. We will be getting started very shortly. We'll just give people a chance to log on. So while people are logging on, please make use of the chat function and let us know what site and state you are from. You may even be joining us from outside of Australia, and if so, we'd especially love to hear where you are watching from this afternoon. Good afternoon again and welcome. My name is Ashley Arkell. I am the National Education Coordinator here at the Stroke Foundation. This is the second webinar in our two-part Somatosensory series. We are delighted to have the expertise of the Neuro Rehabilitation and Research Recovery team from La Trobe University, here to present as part of Stroke Foundation's National Webinar Series. I'd like to introduce you to our presenters today, Professor Leanne Carey and Brendan Haslam. Professor Carey is the lead developer of the SENS approach to help stroke survivors regain a sense of touch. She is recognised as a world leader in evidence-based rehabilitation and translation of neuroscience to stroke rehabilitation. She is Professor of Occupational Therapy, School of Allied Health, La Trobe University, and head of the Neuro Rehabilitation and Recovery Research Group in Stroke at the Florey Institute of Neuroscience and Mental Health in Australia. Brendan Haslam is a physiotherapist working clinically and in research. He is the clinical lead for the SENS program of research, where his role includes training and ongoing support for research therapists in SENS therapy. Brendan has a particular research interest in chronic pain and the contributing role that somatosensory function may play in this condition following stroke. On behalf of the Stroke Foundation, I'd like to thank Professor Carey and Brendan for sharing their knowledge and expertise with us. We look forward to learning from you today. We also have with us Luke Hayes, who is Stroke Foundation's State Manager for Western Australia and South Australia. He will be facilitating our discussion time today. Before we begin, I'll briefly run through some housekeeping. An interactive webinar is a good webinar. We encourage you to use the Q&A function rather than the chat function at the bottom of your screen to submit your questions as you think of them. We will answer questions in the second half of the session. If you see a question that someone else has asked that you also want answered, you can click the thumbs up button under the question to vote for it. All registrants will receive an email with the resources mentioned and a link to the recording. At the end of the session, there will be a short survey where you can also register your interest for a CPD certificate. Before we begin, we would like to acknowledge the traditional custodians of the lands on which we all meet today and pay respects to elders past, present, and emerging. I would like to acknowledge that I'm joining you today from the lands of the Darkinjung and Gurungai people. I'll now hand over to Leanne and Brendan to begin the presentation.
Thanks very much, Ash and Luke. And on behalf of Brendan and myself, I'd really like to thank each of you for joining us today to look and learn a bit more about sensory rehabilitation and what you might be able to do in that regard in your clinical practice setting. So today, Brendan and I would like to share with you some of our work in helping stroke survivors regain a sense of touch and use that in everyday activities. So there's 4 key areas that Brendan and I'd like to share with you today. First, we'll start by looking at sensation and why you might want to address it in stroke rehab, with reference also to the clinical guidelines there. I will then introduce you to sense therapy, in particular the evidence behind this neuroscience approach to rehabilitation. Brendan will then share with you some of the ways that you can apply sense therapy in your clinical practice setting, and we'll finish by looking at ways that we can help to increase access and share some resources with you that might be useful for in your setting. So over to you, Brendan, first in relation to sensation and the clinical practice.
Okay, thanks for that, Leanne. If we can just move it on. Next slide. So really looking at the issue of sensory impairment after stroke, and building on from the webinar 2 weeks ago, this notion, or the fact that 1 in 2 stroke survivors experience somatosensory impairment. So this idea that their hand is blind, this difficulty in interacting with the world around them, difficulty using objects, with using their hand function and grip, all of these things that contribute significantly to difficulties in returning to their previous levels of recreational activities and occupational ones as well. So despite this really common problem of somatosensory sort of impairment post-stroke, it's still very much a neglected area in stroke rehabilitation. This is despite, increasing evidence to show the potential of learning to start to reorganize new brain networks, start to make new neural connections well beyond the 3-month sort of recovery period classically referred to. And really with therapy, we should be looking to get people to regain this sense of touch, but most importantly, with each gain that they make, to be able to incorporate that into utilization throughout the day and ultimately increase their ability to participate in daily activities. So somatosensory impairment is a significant problem, and it's identified as that. Yet despite this high prevalence and the significant impact that it has on stroke survivors, there's still an evidence practice gap present. A recent survey of our group found that over 50% of clinicians, so here in Australia working with neurological clients, stated that they were unaware of the current best practice towards somatosensory rehab. That 80% of them were using non-specific treatments such as compensatory strategies, a third of them using no real specific treatments at all, and less than 50% of therapists actually reported confidence in their ability to confidently assess and treat somatosensory impairment. So there's a huge unmet need there in the clinical community that we're aware of. So what are the current guidelines? And just as a snapshot here of the current Australian guidelines that are now the living guidelines supported by the Stroke Foundation, and also the current guidelines by the American Heart Association, and it lists that sensory discrimination or somatosensory retraining utilising sensory discrimination may be provided. So there's encouraging evidence for it, but there is still this word may, and why is that there? I think this is because the evidence is emerging. It is still very much an area in development, but currently there's been limited number of research groups actually researching this. So, but we have got an increasing amount of evidence showing both clinical effect and translation into functional gains. And this has led to now somatosensory retraining being included in the Biotherapy application as a high-level evidence, which is currently being accessed by the clinical community. For those of you that might not be aware of the Biotherapy app, it is a mobile application for clinicians, for stroke survivors to be able to use on their mobile phone that utilises an algorithm approach and is able to provide a list of evidence-based interventions that may be appropriate for a particular presentation of someone following stroke. So it lists the intervention or the therapy that may be appropriate. It provides a level of evidence. It also provides just a brief overview to the current protocols and available key evidence articles that are there. And if you're lucky, there may be a couple of little short demonstration videos as well.
Okay, so let me introduce you to sense therapy and some of the background in relation to neuroplasticity and evidence for it. So first of all, the phenomenon that underlies a more restorative approach to rehabilitation, as we know, is neuroplasticity. And this approach, it provides more hope and motivation for regaining sense of touch and using it in daily activities. Now, we do know that different mechanisms occur across the recovery process, but our target in neurorehabilitation is this neuroplasticity, and this can occur in the days, weeks, months, and even years after stroke, opening this window of opportunity. So when we're looking at neuroplasticity, there's three different types of neuroplasticity that we could be looking at. There's experience-dependent plasticity, which is particularly linked with enriched environments. Learning-dependent plasticity, where the focus is on skill training. So here the aim might be to regain grasp, or in our situation, to regain touch sensation, for example, discrimination functions. And then there's activity-dependent plasticity, and this is where we're focusing more on strategy learning. And the aim here is for the person to learn strategies that they can use in daily activities and to enhance that transfer of learning and practice over time. So our focus within sense therapy is looking at the learning-dependent plasticity as well as the activity-dependent plasticity. So we've developed up a short video to help show you what we're doing in practice and how that links to the core principles, the core neuroscience behind it. So there's in fact 7 principles of sense, and I'll briefly show you a segment of this video which really highlights how the principles come from the neuroscience. If you like, you can also look at the full video on YouTube there. So I'll just go and...
Translation of neuroscience into an evidence-based therapy. Our research into brain plasticity and learning has created the 7 training principles of sense therapy, each designed to drive the brain's capacity to form new connections. Sense therapy begins with selecting specially designed training tasks. Sense tasks are meaningful, graded, and varied to enhance transfer. These tasks may seem simple to perform. However, the neural matrix of touch is complex. The person with stroke is guided to focus attention on the sensory goal of the task without vision, and to give a response. Attention is critical for learning and heightens the brain's response to the sensation that is focused on. It has a top-down influence on sensory thresholds. Next, feedback is provided on critical features of sensation. Feedback is immediate and precise. Feedback is also given on the best hand movements to explore a particular sensation. Feedback via vision and touch is important for skill learning. Calibration requires the person to calibrate or match their impaired sensation internally by reference to a more normal sensation experienced through the other hand and through vision. The person is also prompted to imagine what the sensation is supposed to feel like immediately after feeling it with their unaffected hand. Calibration improves signal input and helps to realign brain maps. Similar brain regions are active during real-time sensing and imagined sensing. Next, anticipation trials are used. In these trials, the person knows what to expect to feel after having just experienced a similar sensation and being told that only a limited set of stimuli will be used. These prior experiences can help tune into distinctive differences in sensations. Sensory brain regions are also active during the anticipation of a stimulus. Tasks are repeated to consolidate learning. Training then progresses to more difficult discriminations within each training set, and to a range of new tasks. Repetition is vital to establish and strengthen connections. Neuroplastic changes are enhanced when the system is progressively challenged. A matrix of varied stimuli and training conditions are used to enhance the transfer of skills. Feedback is given during the act of transferring skills to new situations. It is the distinctive features of difference that form the basis for skills transfer. Brain networks are important in recovery. Even though fibre tracts may be disrupted, brain activity can remap to damaged sensory regions and form new connections to other regions and networks in the brain, as scientific evidence has shown for Karen.
So hopefully you can see from that how we've actually taken principles both from learning and neuroscience and operationalize them in what we do hands-on with our clients at each session. As part of the development and building the evidence behind this, we've done a number of neuroimaging studies as well. So for example, we can identify, so this shows you some of the changes in the brain potentially associated with the sense therapy. So we identify where there's interruption to the white matter, the white matter tracks going to sensory areas. We're able to map the activation associated with processing texture tasks while a person's in the MRI, so the lesion is, and then to return to those areas, as well as look at some of the network related changes using resting state functional connectivity. Most importantly, this is also aligned with a profile of outcomes from our more formalised sensory measures, but also changes in functional tasks that the person's engaged with. One of our main sources of evidence is from the SENSE trial, so a randomized controlled trial of sensory rehabilitation. So if this trial, if you have a look in the first phase, those who received SENSE immediately, you can see the reduction in deficit or the improvement compared to those who had a control intervention. So it was actually quite an active control intervention in that they had exposure with the therapist and exposure to many of the stimuli at the same time, but not the SENSE principles. And what we see in our between group comparison is a significant difference for those who received the SENSE therapy in relation to outcomes of both texture discrimination, limb position sense, and tactile object recognition. Those who then in the second group, in the delayed group, received SENSE therapy, you can also then see the magnitude of change of the improvement with when they did receive the therapy, and importantly, the follow-up at a 6-month follow-up. It's important to look at these follow-up effects as well, to look at the amount of change and who was able to receive it. So by the follow-up time, both the immediate and delayed group had received SENSE therapy. And if you look to the left of this red line, this is where it's showing the improvement for each of those individuals. What we found is that 36% following training and at follow-up showed sensory function within the normal range, so no longer impaired, and also that 59% showed a greater than or equal to 50% reduction in the deficit. So from that controlled trial, we can conclude that significant improvements in functional sensory discrimination capacity can occur following stroke. We found that these improvements were maintained at 6 months and that they were clinically significant, and thus supporting introduction of sense training, particularly with people who were at least 6 weeks post-stroke and in rehab and home settings. We've also conducted a second randomized controlled trial, which is not yet published, but I thought I would, in addition to replicating the benefits across the sensory discrimination task, we also looked at improvement in self-selected valued occupations, and we used the Canadian Occupational Performance Measure to help pick that up. So for the green group, where they had sense therapy and no treatment afterwards, you can see the magnitude of change in those self-selected activities, so the improvement in those and some further slight improvement. These two groups either did not receive any treatment or received stimulus-specific training, but not training in occupations early, and then in the second phase got training with sense, which allowed them to receive the training in relation to their valued occupations. What we found in terms of the magnitude of change pre-post sense therapy was a significant difference with a pooled mean effect of 9.2 units with the confidence interval showing there. So showing quite a large magnitude of change for that. It's also been important for us to understand the experience from a stroke survivor's perspective of being involved in the sense training. And Megan Turville in our team has done that through the this phenomenological analysis. The findings revealed 5 main themes associated with being involved in sense therapy. Firstly, that motivation, which is connected with the loss of sensation and a desire to reclaim normality. Part of the process was involved a theme around harnessing the positivity in the therapeutic relationship and specialised therapy, recognising and facing some of the emotional difficulties of having this hidden problem that they needed to address, and moving through to very much a distinct awareness of gains and differences in their body sensations and improved functioning, both in terms of control and, most importantly, choice in daily performance. So I'll share with you a couple of the quotes from stroke survivors who are involved with that study. The first is from Maria, who said, "It was from a completely different type of thinking and processing than I'd ever been used to. It was always positive thinking. It was challenging, but I wouldn't have changed it. I knew it was working there." And I think this highlights for us the very active processing, the learning that goes on in the sense therapy. It's not just an exposure or a practice, it's a very active learning. And from Michael, yeah, 100%. Like, yeah, it just like when I didn't have the retraining to when I did, it's like chalk and cheese, just chalk and cheese. It done wonders for me, like in sensation. So for a number of people, we found that was really connecting with what sensation is and what it means, and then being able to take that into how they process the world around them. As Simon said, it has become part of my routine, especially things like transferring what I feel on my good side and critically thinking about that and trying to understand what it feels like on my good side, and then transferring that to my affected side and trying to feel the same ridges on a piece of clothing or top. This really articulates the fact that the person has picked up the strategies about what to do to most optimally make sense of the altered sensation and explore it in the most optimal way. And then the last one, much easier. Everything is different, unbelievable. It's like a glass of water and a glass of wine, but it's true. And now I go for a walk, and if I see a coin, I pick it up. And this is the person I shared with you in the last session, who basically said could feel nothing, had little or no confidence to even go and use his arm in any way. And some further evidence to support the clinical application. Basically, we've also found that there's a change in functional arm use from pre to immediately post treatment and remains at follow-up. So it's a small change, but it was particularly associated with the somatosensory skill outcomes after sense training. We've also looked into individual differences, so who can potentially benefit from this therapy. And in exploring that across all our studies, we can support that stroke survivors can benefit with varying age, with lesion of left or right hemisphere, varying severity of somatosensory impairment, varying cognition, and varying time post-stroke. I will highlight, though, that one of our exclusion criteria is neglect, so just to highlight that there. And we also wanted to look into more to understand the effect of the initial severity and how that might influence response to sensory retraining. You've often heard of the term proportional recovery. Essentially, we did find that improvement was proportional in terms of pre-treatment severity, but most importantly, that survivors with severe impairment can still benefit, as you can see here. And this is the example from the texture discrimination. So I might pass over to Brendan now to share with you a little bit more about what this might look like in application and clinical practice. Thanks, Brendan.
Thanks, Leanne. So in just introducing sort of any therapy intervention, I think it's really important that we try and prime the participant in order to get buy-in. So to really make sure that we give them every opportunity to come on board with us. So important to acknowledge their issues, validate their experiences through the assessment findings that we might have, introduce a plan, and then give reason why it should work for them. Feel free to mention any evidence, and then why could this therapy potentially be applicable to them. So we've just got a quick little video here. Leanne, if you're happy to play.
So thanks for those assessments, Pauline. They've given me a really good idea about some of the difficulties that you're having with being able to feel with your hands, as you've discussed, and also with looking at some of the tasks that you're having difficulty with. It gives me some good ideas as to how we can go about really tailoring the sensory treatment in order to help you out in the best way. Before we start, it's really important to understand that following the stroke, the sensors in your hand and your fingers and the nerves that are connected to those are still intact. So the messages are still able to be transmitted along your arm. What's happened with the stroke is that the area of the brain associated with trying to understand those messages has been affected. So it's more a matter for us at the moment to start to retrain, to teach different areas of the brain how to best understand those messages that are coming in. What we'll do with therapy is we'll train you with lots of different sort of things like textures and the position of where your hand is and the best way to explore different feelings of objects in order for your brain to be able to start to learn some of those sort of new skills or relearn some of those skills. And I'll talk you through about ways that we can best do that. The therapy has been already studied and to show good positive benefit for people with stroke like yourself who've had similar sort of sensory troubles. So I feel really confident about this as a really good treatment option for us to explore, and in order for you to be able to start to get a bit more feeling for things and use your hand in a little bit better way how you're wanting to. Is that okay? Yeah. So thanks for those.
Great, I haven't moved like that for many years at another. All good. Okay, so we're very aware that really this webinar is designed to give an overview and an introduction to somatosensory training options and sense therapy in particular. So I guess it's good to know that there has been a more detailed information that's been developed and put together in a manual for therapists that outlines protocols of delivery, and that is also supported by an accompanying DVD with lots of video footage of assessments of treatments of various components and at various levels. So to know that that resource is there. But today we're really giving a snapshot overview. So as was mentioned in the earlier video of the principles of sense therapy, we look to train particular components. So we look to provide opportunities for training and learning of training of texture, and we'll use, you can see on that picture there, different textures via comparison of texture wheels. We'll also use grids that were used in the assessment of tactile discrimination that was mentioned in the last webinar. We look at training of limb position sense for wrist, for finger, and also for multi-joint, so whole arm positions as well. And then the ability of tactile object recognition, so how to use the best exploratory procedures to be able to identify key features from different objects that then helps for them to recognise what those objects are, and then potentially setting up how they can then use those and interact with them in a better way. So just using those principles as a means of just brief explanation or introduction. First of all, we select a task. So we might select tactile discrimination through textures. We give people the opportunity to explore that, to actually explore the textures, and we'll provide two and ask, do these feel the same or different? Okay. We'll always ask people to produce a response, to provide a response so that they get that sort of questioning in their head. Once they've provided a response, we give them feedback. This is where the learning starts. This is where it stops being an assessment and starts being therapy. We provide feedback as to the accuracy. Did they get it right or not? Okay. What potential features were there that were able that can be used to tell the difference? And really exploring that with them and talking them through and highlighting those different features, and also instructing on the best way that they can potentially explore those objects as well. What is the best way to move their hand over them or to interact with the object to get that key information? We provide opportunities for calibration through how does it feel with the other hand? And then, okay, now you know how that feels. Let's try with the original hand and try to match to that. We can calibrate through vision as well, looking at the various features while the person is interacting through touch over them as well, which gives them the capacity for people to imagine the surfaces or the object and prime their system ready for that. This sets us up for anticipation trials. So going through saying, okay, so now we're going to do some more of these particular surfaces or objects, but we're going to provide ones for you that are going to be the same level of difference. So there won't be any surprises. You know what's coming, but I'll ask you to feel it, try and identify differences if they're there, and let me know if they feel the same or different. We then repeat, progress, train them as they're able to get 75% or more correct, but also within a reasonable time frame, okay? If it takes too long, then it's not at that automatic functional sort of perspective. And then transfer it, vary the stimuli, change the environment, and incorporate those skills into the performance of different tasks. Next slide. So what we've got here is just a video of an opportunity for therapy using object recognition, in this case, a knife and a spoon, and just look at how the feedback is provided, how the opportunities for exploration are really brought forward and presented to this particular client.
In level 2, medium differences are trained. The two objects presented have a substantial amount of difference between them, but less than for level 1.
Our first task will just be to feel it, and then I'll present two objects, and and if you can tell me if they're the same or different. So this is the first one to feel, placing the object in your hand now.
No, not at the moment.
Okay.
Don't have a clue.
Okay, I'm going to place it near your thumb and your index finger, and help guide it a little bit so you've got a bit more of an opportunity to feel that. Okay. Now I'm going to give you the second one. And I'd like you just to tell me, are they the same or different?
No, I don't know.
Okay. So you're not sure if they're the same or different?
No.
Okay. Have you got any idea what type of object it could be?
No, I haven't got a clue.
Okay. So what I'm going to do now is I'll just help guide it through your hand a little bit more fully. So we'll start around the bottom part of the object. I'm moving it through your hand and guiding your thumb across the border of it. Okay. And I'm place the second object now and we'll do the same. Okay. So I'm just placing it into your hand and guiding just across the around the outside, around the border of the object.
It's something a little bit sharp, not sharp, but I can just feel a little bit.
A little bit of something?
Yeah.
Have you got an idea, or would you like to guess what it could be?
Well, if I'd said a fork, I don't know.
You don't know. Okay then. So maybe this one's a fork. Did the one I present to you before, did it feel the same or different?
No, I think it was different.
Okay.
This is something.
Okay, so that there might have been some difference.
Yeah, I don't know.
But you weren't clear what it was?
No, I don't know.
Okay.
In level 2, medium.
Great, we'll move it up. Great, and I think that gives a good example of things, but also highlights the fact that we will be training people with sense therapy with varying levels of active movement as well. So not having necessarily fantastic active movement should not be a barrier towards experiencing benefit from sense therapy. What we have also developed, or what a group has developed, are also therapy sheets to basically help document a therapy session. But what they also critically do is that they provide prompts for the therapists to be able to work through their therapy session. So for this example, we're using cutlery. We're presenting objects such as a soup spoon and a fork. We'll ask them, present it first of all, give them a chance to explore. Do these feel the same or different? Be able to indicate that, okay? Do you know what they might be? What tells you that they're the same or different? So that it gives you this guide through, and then the therapist has the potential to also look and identify and record what exploratory procedures that person is using to help identify that object as well. Moving on. So, as well as the component training, there's also, as was mentioned, some occupational-based sensory training that utilises a more cognitive strategy approach. It identifies tasks using the Canadian Occupational Performance Measure, measured for performance and satisfaction. It then involves looking at those tasks, observing how the person is performing them and analysing and identifying potentially what impact sensory impairment may be having in the performance of those tasks. That then gives the opportunity to identify particular components that may be beneficial for that task, particular difference in textures, various things that we can train those skills up, but then also introduce a cognitive strategy approach to identify where the person is having difficulties, how they might utilise their skill set to then be able to learn a different way to be able to perform that task or to refine how they're currently doing it as well. moving on. So a brief overview of these core elements. We can see that the capacity training or the component training, textures, limb position sense, object recognition or exploratory procedures, follows those principles, okay? But then as we introduce also the occupational task, it involves those same principles coming through and the ability for feedback and calibration, okay? But it also has a cognitive orientated approach. So the developing of a strategy that progresses in refinement towards the ultimate task.
Great. So we might move on to some ways we've been looking at to try and increase access and some resources we'd like to share with you. So to try and facilitate increased access, we've actually developed a partnership with consumers, clinicians, service organisations, researchers and academics to try and develop up a network of sites and upskilled therapists to deliver best practice stroke rehab for the upper limb. So it involves both a central core translation hub here, which focus on the knowledge translation, champion therapists for upskilling, neuroscience therapy. This links at present with 8 existing healthcare networks, and so we've been looking at upskilling therapists there, as well as we've developed up 4 specialist therapy clinics. And so here we're looking to develop up therapists who can really become expert in the area, and that we can also encourage stroke survivors who might be in the community to be able to access this therapy at these centres as well. Part of the approach has been to set up a research translation study to really try and change practice and to build confidence in clinicians in clinical practice settings. And we've had a pragmatic study with within and between site, looking at within and between sites before and after study at 8 Australian healthcare organisations. At baseline, we have questionnaire and focus groups to understand where the therapists are starting from. Therapists then receive training in the quantitative somatosensory assessments, and then during that phase, patients receive usual care. Therapists then go on and receive training in sense therapy, and they get the opportunity to deliver that. And then we have post-implementation questionnaire and follow-up. We've also more recently developed up the Sense website, and in this way we're wanting to reach out, communicate with more people, from people who might experience strokes, families, health professionals, research, etc., but also within the core team to develop up a community of practice. In relation to resources that might be of interest to you, in relation to sense therapy, as you can see here, there's information overview, what it is, the principles, how to conduct sense therapy, evidence for sense therapy, and even Sense for Kids. We've done that. And for health professionals, some knowledge background there in relation from the loss of sensation to the neuroplasticity and the evidence-based therapy. So welcome you to have a look at that resource. I'd like to quickly now pass back to Brendan and for him to share a bit of reflection about bringing this sense therapy to practice as a key lead to upskill people. Brendan?
Thanks, Leanne. So for me on reflection in my role as a sense therapist in the study that was reported earlier, and then going on to be a trainer for other clinicians, there's been a couple of really key things that I think are important. One is how satisfying it is to be able to provide a service that has such meaning to clients that previously just hasn't been able to be accessed. But I think another thing to be really aware of is that for stroke survivors with somatosensory impairment, they've often tried to do the best they can despite the sensory impairment. And sometimes it can be quite confronting to sort of almost expose the client as to getting to realise just how significant the somatosensory impairment is. And it's really important to I guess, acknowledge this vulnerability and also make sure that you frame things as an opportunity as to, by skilling them up more, it leads, this creates more opportunities for greater performance than what they were already doing. Where they've been trying their hardest, let's give them a little bit more resources because they've done this without the sensory the skills. So, really take it as a positive experience. Looking in as sense therapy in the studies, as Leanne has mentioned, we've now pretty much trained up about 170 therapists throughout these sort of studies who are able to deliver therapy in these sites. And the upskilling process has been really, really fascinating, of providing the training, providing practice opportunities during the training sessions, but also independent with partners and things. And therapists have started to feel really empowered. This ability to access and provide something that wasn't normally available. It's also been really valuable to highlight this observational process where a therapist, while they're practicing, has had the chance to be observed either by myself as a trainer or one of their other therapists, one of their other colleagues, in order to be able to get feedback as to how well that was done or various things. So this idea for constantly reflecting on clinical practice and driving that improved performance has been a really exciting feature, I think, of the study so far. So we've also, had a lot of frequently asked questions, the classic ones that we're producing responses to and clinical situations, but it's what if the person doesn't perfectly fit the script? What if they're just not this absolute dream patient ready to roll? What if they have increased tone? What if they have very little active movement, if any? Can you apply sense therapy? What if they have pain? What if, to touch stimulus is painful, or if there's fatigue? And certainly, none of those should be seen as barriers to sense therapy. What it does is it provides, I guess, more opportunities for reflection and really tailoring the program and utilising the principles directed to that person rather than the one size fits all. So it is very much therapy guided by these underlying principles of providing opportunities for exploration, giving feedback, providing calibration, and constantly refining within that person's capabilities that address that person's needs. So moving on, current opportunities for people that are out there at a clinician level. This is very much a greatest hits sort of webinar, I guess, but a two-day workshop. We are actually very excited delivering in person, sort of, don't know how I'm going to go with that personal space, but that's okay. At the end of March here in Melbourne at the Florey Institute of Mental Health, Neuroscience Mental Health. If people are interested, there is a link there. We are in the process of developing and refining an online training that will be available sort of later in the year. Again, people can express interest there. But I want to stress also, and I appreciate there's a lot of clinicians out there, that if you identify some of your clients that may have, Leanne, if we can go to the next slide. If you have clients that do have somatosensory impairment that you don't feel you're able to provide for whatever reason at this point, there are opportunities in Melbourne, Newcastle, and in Adelaide for where those sense therapy centres, those clinics now are able to see people in a face-to-face environment and provide a program of sense therapy for that. So, and Irene's contact there is there for people if they have anyone of interest or want to make some inquiries about that. And just to acknowledge the incredible work by an incredible number of people in bringing everything of this together and moving it forward. And that's it. Leanne, do you want to do conflict of interest?
Yeah, no, that was more, yes, really acknowledging the whole team. I think, as you can see, there's a lot of perspectives, there's a lot of work that's gone into this, and a lot of commitment. And the commitment is there because we're hearing from the people we're working with, the people who've experienced sensory problems, how much this is an important issue for them. So we're working with that. I'd like to just recognise that I've been involved with this for a long time, and what our aim is to provide resources that people can use, and so that there's no financial benefit for me for any of this, but it's basically to be able to get it out there and to really thank you all, and open to questions with both my own and David and Brendan's email addresses there. So we might stop share at that one and open up to the group. Thank you. Luke.
Thank you so much, Leanne, and thank you, Brendan. We've got quite a few questions that have come through, and we may not be able to get through all of them. But starting from the top, Ashley Glynn asked, do stroke survivors with neglect not benefit from sense therapy, or is it in your trial that they were excluded from that trial?
Yeah, it was essentially that in our trial they were excluded because of the potential confound. Clinically, I have worked with people who have neglect and have been able to see that some ability to process and recalibrate what's going on, but it hasn't been formally tested in that subgroup. So that could be another little avenue along the way. Did you want to add anything to that yourself, Brendan?
I mean, I think just because it hasn't been tested doesn't mean that it's not applicable. I've certainly worked with people with neglect in clinical practice, and we're doing them a disservice if we don't give them every opportunity, and certainly have seen benefits.
Incredible benefits still. Yeah.
Thank you. And the next question was about the results from the sense trials, how they compare to expected or natural recovery that some stroke patients experience, i.e. compared to no treatment.
Yeah, so with the randomized controlled trials, we have the control arm, for example, in the SENSE study, the people were receiving fairly much what was best practice in sense rehabilitation, sensory rehabilitation at the time. So for example, they had exposure to textures, were even moving their arm for the limb position, etc. But until the comparison is with the application of those principles. Similarly, in the Connect study, some had no treatment versus treatment, or a stimulus specific training versus no treatment as well. And we have actually also done a whole series of studies where we've been able to monitor people in terms of with repeated assessment during spontaneous recovery as well, and then gone on and done the treatment. So we have a fairly strong comparison with that, and we're now really looking to define, by pooling all our studies, benchmarks of what magnitude of change you might be aiming to achieve if you're delivering this therapy yourself in clinical practice.
And just building on Leanne, I think you're being quite modest there. I mean, I think we need to mention that the participants were in subacute, but predominantly a chronic population. So most of them were outside of that period of spontaneous recovery.
Yeah, most definitely. And also we've got the brain imaging changes. We've actually seen how the brain activates differently after the therapy.
Okay, that's a great answer. Next question is, and I think you covered this at least towards the end, but did you want to expand on there being any other resources available online that detail the sense principles that clinicians can access?
I'll run with that. I think the website that is there has a lot of video input, a lot of links to references, key things like that, various media things as well. So it is very much designed to be an ongoing resource pool for clinicians to be able to refer to, and to then make them aware of other stuff that is out there. So yes, very much there is this resource pool embedded within the website that we are adapting and updating as we go along. If people want more information, then, as I said, we've got those experiences, those opportunities for clinicians in a face-to-face environment, but also, you know, in the new online world where we're slowly sort of adapting, and that gives us an opportunity to reach more people, and, you know, even the international queries that continually come through. Can we provide training? We're taking steps towards it. At this stage, here's our resource package, here are our opportunities, but watch this space.
And we have the manual and DVD, which is very accessible, and now we've put that into electronic format so we can actually share that as well.
Yeah, and that's got videos of all exposure to various textures, limb position sense, object recognition at various levels. It's got lots of great stuff there.
Needs a bit of update, but it's there.
Fantastic. And that probably leads on to the next question, which was just a reflection on how much rehabilitation has moved to a telerehab or telehealth approach. And can you sort of expand on the ability or flexibility in the program for patients to participate in sensory retraining via telehealth?
Yeah, so we're actually systematically looking at that. We're looking at developing up Sense at Home, where the plan is to be able for a buddy working with the stroke survivor in their home to be exposed to doing the training and such, because often you need somebody to guide the hand, etc. And then that can be facilitated by the clinician guiding them through. And so we've got different levels of which we're going to start with a hybrid and then a fully remote. But I also haven't talked about early on in the piece, I actually trained up carers in the home to deliver the therapy in the person's home. And then I came in every now and then just to check how it was going. So I think there's scope there, a little bit of systematic development with the need for the equipment and adaptability, etc., which we're looking at.
Interesting point about carer as therapy assistant.
Works with
yeah. Jenna Amos asks, obviously the time taken and intensity will be different for each patient, but are you able to sort of reflect on the intensity required to achieve positive outcomes on average?
Yeah, thank you for asking that, because I realised I forgot to mention that early along the way. So in the early sessions, we were doing 15 sessions. We're now doing 10 sessions over a 4 to 6 week period. And each session is approximately 1 hour. And within that 1 hour, we have components of training. We have 3 20-minute lots, and you can do either component training, for example, of texture and objects plus occupational, or you can mix it around. So we very much grade it through. So it's actually got that whole framework to do it. But sometimes it's quite surprising how much they can change within just 10 sessions. And we have so many aha moments where people say, now I get it. And yeah, and then they learn the strategies to use it themselves.
I think, yeah, a key thing from that, but also in provision of practice opportunities in between the sessions where people really consolidate and that. So you see changes where people come in having consolidated skills further, and the work that they're doing outside of the therapy sessions is you know, every bit as important as the actual contact therapy sessions.
Thank you. I'm aware that we've probably only got a couple of minutes left, but there's time for some more questions. New Milton asks, do you provide pain, temperature and crude touch retraining, within brackets the anterolateral tract?
Sorry, Luke, you went blurry on that one for me. Can you go again for me? Is that all right? I think it's on.
Sorry, yeah. Yeah, so the question was from New Milton. Do you provide pain, temperature and crude touch retraining, and in brackets the anterolateral tract?
So let's keep it clinical if we can. From a touch, from an exposure, absolutely. You're looking to train that identification of when they come into contact, and we use a lot of visual strategies as well to really refine that and create that awareness of contact. So and we've seen people make those changes during the therapy session where they've gone from not being able to detect anything to being able to be aware of the stimulus and then having some capacity to tell some difference. There's certainly scope from a temperature perspective as well, of training of being exposed to differences of the temperature of different objects, and that's a discrimination task that's in there. From a pain perspective, I think we very much need to consider that pain is this output that occurs when someone ultimately is provided with information that feels threatening and they feel vulnerable. So it is more about how we deliver, how we introduce the training in a means that feels safe, that the person feels very, very secure, and then able to start to engage in the stimulus and to be able to pick out the differences, so that we would expect moving forwards that exposure to those stimuluses should be less likely to produce a pain response because they've started to analyse the objects, the stimulus for what it is, rather than having it as a position of potential threat.
Mm.
And it's interesting, anecdotally, to begin with, we have people who are involved with sense. And I remember somebody had this incredible hypersensitivity, and I thought, oh, is this, reasonable to do? But they actually reported that reduction in the pain. And Brendan has, alongside this, been now taking measures of pain, and we're seeing some incredible changes in that. We're not directly targeting the pain in and of itself, but seeing some quite positive outcomes from that. But I won't steal Brendan's thunder because that's going to get out there fairly soon, so look out for that one.
Thank you again so much, Leanne and Brendan, and I'll hand back to Ash. But before I do, I hope I'm not putting you on the spot, but we do have a list of quite a few questions. Would it be possible if we could bundle them up and provide them to you for some sort of response? And then
we're happy to do that. Yeah, no worries. We'll put that together, and I think there were a couple left over from the assessment one. We're happy to do that as well, and we'll share it back with you and with everyone who's here today. Thanks.
Wonderful. Well, thank you so much, Professor Carey and Brendan, for sharing your knowledge and expertise with us over these last two sessions. It has been absolutely fantastic to learn from both of you. You can provide feedback on today's session, request more information about SENS therapy, and register to receive a CPD certificate by completing our survey. The survey should be loaded onto your browser now. Otherwise, you can click the link in the chat. Also, if you would like to receive invitations to upcoming webinars, there is a link in the chat where you can subscribe to the National Webinar Series mailing list. A big thank you again to all of you for your fantastic questions today. Keep an eye out for those answers coming from Professor Carey and Brendan in the coming weeks. And thank you again, Professor Carey and Brendan, and for all of you for joining us today. Bye for now.
I think especially to everybody who's joined, because we need to change practice. So thank you. Great.
Absolutely.
Bye.
Bye.
Bye.